The next speaker is Professor Chih-Hsin Yang. Professor Yang graduated from the National Taiwan University and obtained his MD and a PhD degree in NTU. And he received his completed internal medicine and the medical oncology training in National Taiwan University Hospital. Now he is the president of National Taiwan University Cancer Center. And Professor Yang is a world-renowned lung cancer expert, and he's the major leader for the development of the several important lung cancer treatment. Today, Professor Yang will give us a talk about the immunotherapy revolutionized stage 1 to 4 lung cancer treatment. Let's welcome Professor Yang.
Thank you, Deputy Yang, for your kind introduction. So my role today is to summarize what has happened in the past 10 years about using checkpoint inhibitors in lung cancer and how the checkpoint inhibitor has revolutionized the lung cancer in total. So this is a very simple graph to show that cancer immunology has evolved over the 100 years from the Corley's toxin as mentioned before until 2010 when we first start to use checkpoint inhibitor PD-1, PD-L1 inhibitors in the clinic. But over this 15 years, we have overturned the world and has used checkpoint inhibitors in the clinic as a first choice of cancer treatment, at least for stage 4. But as my title has said, it has already revolutionized also stage 1 to 3 non-small cell lung cancer. So I'm going to summarize what we have done for these patients and what outcomes these patients had improved over the years. This is a very simple graph to say that cancer cells as living contributions to this is enormous to inhibit the T cells attack, cytotoxic T cell attack, and convert that to exhausted T cells so that this T cell has no more functions. Yet if you block this checkpoint with checkpoint inhibitors, T cell will revigorate and attack cancer cells. But this only accounts for roughly 20 to 25% of what happened in at least for lung cancer, and it's probably even less in other type of cancer. So what happened is that PD-L1 expression in tumor cells is very different from what we have learned from lung cancer in the past. Lung cancer, we know, is a very specialized solid tumor in that a lot of lung cancer has its unique driver genes as well as biomarkers. But for immunotherapy, this is something new that we have learned that in lung cancer, at least in the lung cancer tissue, the expression of PD-L1 is roughly heterogeneous. And in addition to that, a lot of studies have shown that PD-L1 can be induced by some oncogenic pathways such as EGFR. This has been shown in the in vitro models and probably also in humans as well. And PD-L1 is also subjected to change in tumor microenvironment. And sometimes PD-L1 high expression cannot predict for outcomes for checkpoint inhibitors simply because these T cell functions, T cell traffickings, and also neoantigen presented by HLA were not checked on these cancer patients. And in addition to that, we all heard about a lot of lectures today that there are a lot of inhibitory factors that inhibit these corrected T cell function to happen. But over the years, we know how many patients had profited from this kind of treatment. So this is one of the earlier phase 3 studies on patients who had non-small cell lung cancer failed 1 or 2 lines of chemotherapies. So here, these two are called Checkmate 017 and 57. 2 studies, one for squamous, the other for non-squamous, randomizing 270, 580 patients to this is PD-1 inhibitors for BMS versus standard dose chemotherapy as a second line. As you can see here, nivolumab has a much better survival curves over the years. This is a long-term follow-up for these phase 3 studies. 13.54% 5-year survival rate over 2.6% survival rate. You think this is a very, very poor outcome, but yet it was a very huge improvement for stage 4 non-small cell lung cancer for almost 0 in 5 years to 13.4%. And this is after chemotherapy. So 2 studies have shown very similar result after a single checkpoint inhibitor treatment for 2 years. But what happened was that if you think that checkpoint inhibitor is useful, probably it's better to use as a first line, because after chemotherapy, a lot of immuno response has been altered. So first line treatment probably will be much better than chemotherapy treated patients. So this was a monumental study called KEYNOTE-2024. So KEYNOTE are all the studies for pembrolizumab. This is a PD-1 inhibitor by Merck. So this study randomizing patients who had high PD-L1 expression, by definition 50% or more PD-L1 expression in tumors, to 1:1 to pembrolizumab alone versus standard of care chemotherapy at that time. Patients who had failed this chemotherapy had a chance to cross over to pembrolizumab. So this was a first outcome that presented a huge difference in overall survival if you use this as a first line. Remember, many patients in this juncture has also crossover to pembrolizumab. So here at 2 years, 51% survival versus 34.5% overall survival. So this is a huge improvement. Remember, these patients had a overall survival 2 years, roughly at only 20% at that time. So after 5 years, what happened to these patients? These patients had received pembrolizumab alone. Some of them, of course, had relapsed, but then they have received additional treatment afterwards. But this was their 5-year survival curve. As you can see, 32% overall survival. These are stage 4 patients who some of them had never received any chemotherapy. So with this curve, I think certainly checkpoint inhibitor has revolutionized stage 4 non-small cell lung cancer survival curves. As you can see, this is a control arm. This is also not the typical control arm that stage 4 patient had, because the 5-year survival for these patients was 16.3%. As we know, in that particular time, patients were accrued between 2014 and 2016. The 5-year survival stage 4, if they have not received any immune checkpoint inhibitor, was roughly only 1 to 2%. So these patients obviously had benefit from crossover, but yet crossover is not good enough. You need to use that as a first line. So these patients had a very good survival. So what about patients who had the lower expression of PD-L1? So we know that only roughly 15 to 20% had high PD-L1 expression. So do we abandon the rest of the patients who had less PD-L1 expression? Probably not, because there are many other studies show that in addition to chemotherapy, which was a standard care, adding checkpoint inhibitor pembrolizumab here, this is KEYNOTE-189, the most commonly used regimen nowadays. 2:1 randomization, 600 patients. Here, this regimen were only used for 2 years and stopped. And here, crossover to pembrolizumab. There was striking difference between these two. Here were the curves after 5 years of follow-up. Of course, not as good as high PD-L1 expression, but yet with low PD-L1 or even no PD-L1 expression, adding pembrolizumab, you have 20% 5-year survival. So this was also a striking difference compared to what we had before. Even the control arm showed 11% overall survival. These were the patients who 60% had crossover to pembrolizumab and had actually also benefited from this treatment. So that was for non-squamous or adenocarcinoma. For squamous carcinoma, a similar study was designed, Keynote 407, and very similar design, but pembrolizumab was used in the combination with paclitaxel because this time pemetrexed is not a good drug for adenocarcinoma. So this is for squamous, and most of them, of course, were smokers. Again, striking difference between these two. 5-year survival, similar to adeno, about 18%. So when we see this 5-year survival, we know that we have changed the natural history of our non-small cell lung cancer stage 4 patients. And these patients deserve a better treatment, which is for PD-L1 high, monotherapy is probably good enough. For PD-L1 low, less than 50% or even no expression, they can have combination with chemotherapy. And we can save 20% of patients at least. But what about adding CTLA-4 inhibitors? This is a very, very complicated, huge study, CheckMate 227. I don't want to go to the detail because it's too complicated to understand, but just show you the result. Patients were randomized first line to nivolumab, ipilimumab, so this is double checkpoint inhibitors versus chemotherapy or nivolumab alone. Interestingly, nivolumab compared to chemotherapy wasn't that effective. Nobody knows why, but this was what happened. But combination seems to be much, much better. And this curve showed the combination arm at this 4 years, 37 overall survival for those who had high PD-L1 expression compared to those who received chemo, 20%. So this was actually also better, but for us, for many of us who are doing clinical trials every day, we know that we have to know who are the patients who are randomized. Usually these patients who were randomized in 227 were better patients because we know that ipi-nivo is not that simple combination to be used. So probably we cannot cross-trial comparison because of these reasons. But yet, you see a striking difference between these two over chemotherapy. And this is what I think the most interesting result. These are the patients who had no PD-L1 expression, but yet they benefit from combination. Here, 24% 4-year survival for non-squamous, 25%, and squamous, 22%. And here, no PD-L1 expression. You may want to ask if we are using PD-1 inhibitors and there is no PD-L1 expression, why does this drug even work? But you know, when we do tumor biopsy, we only check one time point and one site. Probably the heterogeneity may account for some of that. Anyway, this was the result. And this has become the standard for many parts of the world for no PD-L1 expression because of that. And if you think that these 3 studies were only one that I can show to you, you're totally wrong because we have done more than 20 studies to prove that these patients definitely had improved their outcomes. So these are the patients who had monotherapies here, so many studies for nivolumab, pembrolizumab, atezolizumab, this is a Roche compound, and also this is for Sepulimab, this is from another companies, and for adding to chemotherapy at first line, this is a study that I already mentioned, and also Atezo Empower studies. This study is even more interesting in that this actually Liping's presentation has solved some of the mystery of Empower 150, because in this study, the arm that worked best was the one that actually add Avastin or bevacizumab to atezolizumab and chemotherapy, and this arm actually is the best. So why does this even work? Why does bevacizumab even work with combination with checkpoint inhibitors? It used to be a mystery, but it has to be to do with VEGF inhibition that everybody understand. But how VEGF had helped immune system from Lipin's inhibition of CD93 probably had partially answered this question, because by removing VEGF, probably you downregulate CD93 and you induce T cells to go into the tumor site. And that probably is the reasons why this arm is better than 3 combinations. Anyway, there are many studies that have shown to be useful and had improved. As you can see, majority of them have shown positive results both in overall survival, but probably not good enough progression-free survival. And this is an interesting part of immunotherapy, in that at the end of the day, the overall survival is better, but if you count median PFS, you probably don't see the difference, simply because the patients who had responded to this treatment is less than 50%. That means we probably need to see this fraction of patients who benefit more. So when we use biomarkers in lung cancer, we must know that for target therapies, it is a single biomarker. We know they have drivers. And if they have drivers, we inhibit this biomarker. And so this is so-called binary. If you have EGFR mutation, you have. If you don't have EGFR mutation, you have something else. So this is different. It is intrinsic. It means that if you have EGFR mutation, it resides in every 100% of tumors. And this is very unique for solid tumor, I must admit. And it's highly selective, specific resistance alterations is definitely to come. And we can predict how it evolves. You can develop T790, for example, and with bypass pathways. But for immunotherapy, it's another story, because you then have multiple biomarkers. We know that PD-L1 is the best biomarker, but yet there are other biomarkers such as TMBs, such as STK11 as a negative biomarkers, etc. But none of them were sensitive or specific. It's limited to resistant. We don't know nothing about IO resistance at this moment. So here are the biomarkers and also negative predictors. The most important negative predictor actually is the presence of driver mutations. We learned this in a very hard way, because when we start to know that PD-L1 is a very good biomarker, we start to treat our patients with EGFR mutations with checkpoint inhibitors. You can imagine that none of them actually work. There was a study done by UCLA, Eddie Garron's group. He was quite interested to accrue patients with very high PD-L1 expression with EGFR mutation. After 10 patients, he abandoned the study because only 1 patient responded. And so he was very interested in that patient and did redone the bioanalysis and found that this patient was EGFR negative. So, so that was what happened. The presence of EGFR mutation, ROS1, ALK, they are immune, not cold, they are immune freezing environment. So you cannot elicit any immune reaction in these patients. But is that really true? We went back to work with Sydney Cancer Center and did this meta-analysis and check all these studies, and found that the patient who had EGFR mutation in these studies actually had a hazard ratio more than 1, meaning that it's useless to use immune checkpoint inhibitor in these patients. So we know how to select these patients, but it is problematic because PD-L1 always comes first. When we do clinical in the clinic, PD-L1 results always come back with pathologic result, but yet we will have to wait for another week for other biomarkers to come. So then what do we do? Do we start PD-1 treatment or we wait? So it really depends on where you live. If you live in Asia, probably you better wait because you have 50% of the chance to have an EGFR mutation and other probably genomic alterations. Then you have to use target therapies. But if you are living in the United States, you're Caucasians patients, probably you can start with immune checkpoint inhibitors plus minus chemotherapies. But But I actually still have my intention to see whether these patients are really not responding to immune checkpoint inhibitor, because we saw patients who responded, probably not too many, but this is good enough for us to propose this huge study, 500 patients, patients who had EGFR mutation, failed first-line EGFR TKI. Here, we actually presented this in this year's American Society of Clinical Oncology as an oral presentation, highlighted here patients who had failed first-line who had EGFR mutation, failed osimertinib or any EGFR TKI, who had no TCF7 were randomized to standard care chemotherapy or plus pembrolizumab. Of course, they can cross over, but we know this crossover probably will not help. And very surprisingly, well, not really surprising, well, it failed, okay? Almost no benefit. But the hazard ratio, as you can see, 0.84. How many times have you seen hazard ratio 0.84 for overall survival in EGFR mutant? I can tell you that most studies, almost 100% of the study we see for overall survival, at the end of the day was 1. Because none of the studies for EGFR mutant can change overall survival. You always see crossover effect, but for immunotherapy, we did change a little bit, but it was not statistically enough to show the difference. It was a negative study. But what's more interesting was patient who had PD-L1 expression, because you can see hazard ratio has down to 0.77. And this 0.77 means something, because as I said, we never see hazard ratio less than 0.9 in all these studies, and 0.77 really mean a lot. And this, as I said, these are immune freezing environment, but half of a patient did express PD-L1. So I do believe that we have to confirm this. And this is not the only study we have proven that patient benefit from this kind of a combination, although it's a negative study. But another drug that was used in a similar study, much less patients, 270 patients, we also see same result. That patient who had PD-L1 expression, you get a better PFS, but that study also failed because patient was just not enough. The reasons why we believe in this is one of patient who had EGFR mutation. Here, multiple metastasis lymph node, and he actually had a pseudo progression. He only received one drug, no chemotherapy, PD-1 inhibitors. As you can see, pseudo progression after 10 days. After 2 months, almost very good response. And these exceptional cases make us believe that immunotherapy is still something that we can waiting for patient who had EGFR mutation. And in our tissue, I have no time to show to you that these patients also had T cells. Although very few. It's like in Northern Pole, you still see polar bears, and they are doing something, they're fishing, right? And they probably still can work, and we just try to save them. But I have two minutes left to tell you that there are more to come, because for stage 1 and 3, there are huge difference here. We still need to save them. Even for this is stage 1, this AJCC 8th edition, the most recent one is nice. Here for stage 1, A3, 5-year survival was only 77%, very, very poor. And if you go down to 3, 13%. There are a lot of patients to be saved. This study was very, very important. It was just published in this year. Patients who had stage 2 to 3B, who were resectable, were randomized to immunotherapies plus chemotherapy before surgery. So this is neoadjuvant approach, and after that, 1 year of immunotherapy. So this is what I want to show to you. Huge difference. This was their result beforehand, and the standard treatment, and these are the patients who received this combination treatment. These are event-free survival. If you think this doesn't count, we want to see overall survival. I show you the overall survival. Hazard ratio 0.73. This was in ASCO this year. Statistically, still not significant, but after a few months, 3 years follow-up, now statistically totally significant. We know that we have changed our paradigm for stage 2 and 3. If they do not have driver mutation, this is a condition here, you must give them IO plus chemo. Otherwise, you will lose 15% of the patient after 4 years. They will die. So we have changed our history. And this is not the only study. There are many studies. I borrowed this from Dr. Mitsudomi. He has made this very interesting slide that some of these studies has already successful. And for adjuvant treatment, it will take a further step. But these patients probably are not as good as a neoadjuvant plus adjuvant combination. And here are these curves. As you can visualize that these are probably better than this adjuvant approach. This adjuvant doesn't seem to be much better in terms of overall survival outcomes. So what about unresectable? So the only thing, the last 2 slides I want to show to you, unresectable also benefit from immunotherapy after concurrent chemoradiotherapy. This is standard care. We can save 10% of the patients with immunotherapy. So so these are the study over the 10 years we have done. More than 5 drugs been approved in lung cancer indications. All kinds of combinations, mono, combo, neoadjuvant, adjuvant, anything. Anyway, we have saved 10 to 20% of patients' life, not their event-free life. So for metastatic, 5 to 10 years survival is not a miracle now because we saved 20% of patients. And for stage 2 and 3, more lives were saved. And Merry Christmas. This is our Christmas tree in our cancer center. Thank you very much.
And for the great talk of Professor Yang.
That was a ton of data, remarkable. I had a question about your idea about the driver mutations. So those lung cancer patients that are EGFR driven or ALK driven, is it because they have in general a lower number of somatic mutations and thus they are frozen tumors? Is it that simplistic or not that simplistic?
Yeah, it's a simplistic view. It does have very low TMB, and they do have much less mutations in their tumors. But the thing is, it is a good immune target because think of that, they do have a single mutation that can be presented by HLA if they can be. And so they could be immune target. But over the time, these T cells were exhausted. But what my collaborator told me, they are not only exhausted, they are called terminally exhausted. I don't know what this means, but it means that it cannot be saved by PD-L1, LAG-3, TIM-3, etc. It has to be saved by something else. So these T cells actually are present in tumors bed, but we just have to know how to save them.
So there's just not enough neoantigens stimulated, or there's some sort of inhibitory environment?
Well, the thing is that the presence of exhausted T cell means that they have been exposed to tumors. These T cells were exposed, and they were exhausted. That means they did not respond anymore, and they are dying. That means T cell keep on attacking them, but they just keep on dying.
Okay, so I think we discussed this before, that now the lung cancer, even PD-L1 expression, low or without expression, there's still 10% response rate, right? So, and I remember that all 4 those anti-PD-1, PD-L1 therapy, at the time, at the very beginning when clinical trial was done, it already noticed that in addition to PD-L1 positive, which responds, so that's why drug was approved. Yet all the trial all have around 10 to 15% of patient PD-L1 negative but still response. And I think I discussed with you before that PD-L1 was heavily glycosylated, And when we actually found that by remove glycosylation from the tumor tissue, from the immunohistostaining tumor tissue, that we could actually detect PD-L1 better. Although lung cancer has not been tested yet, but in lung cancer you have plenty of tumor tissue. In breast cancer, actually was right here. I was a progress report yesterday that using the reason that the breast cancer is because of atezol. Because atezol was approved for breast cancer in 2019, but 2 years later was withdrawn, right? So for Genentech, it's a big loss. But we start with the breast cancer first from Taiwan, 6 different hospitals collect the PD-L1 treatment, and then currently all the data we show look like if we remove glycosylation from tumor tissue, and then their expression level was increased. Then if we use these two groups, turn out to be the PD-1 level higher after glycosylation, survival is better. Although it's only about 77 patient data, we probably need to collect more in breast cancer. Breast cancer is primarily because of atezol, because it was not disapproved. But for lung cancer, I understand lung cancer right now, all the traditional therapies, you don't care because the PD-1 expression has no prediction power. So regardless of positive or negative, you still treat them. But in the future, if assuming by deglycosylation can really predict the response rate, then there may be some clinical thought that that should be tested.
Yeah, that's a very good observation, and I think Lipimo much better than many people here that the test of PD-L1 has been a disaster for lung cancer for many years because there are so many antibodies that are used in the clinic, and then people start to make papers from comparing antibodies to antibodies. And the standard of antibodies that we use for immunohistochemistry nowadays usually is 223. Of course, that has probably cannot detect the modification glycosylations. I believe there are room for improvement because, as President Hong says, roughly 10% of patients still respond if they have no PD-L1. And on the other hand, 50% of patients with very high PD-L1 expression do not respond. So we still need to figure out why. And so this is not a biomarker similar to EGFR. This is a very completely different, it's a continuous variable that we have to deal with. And in addition to continuous variable, there are different things that we have to check on these PD-L1 quality.
Yeah, I agree with you that maybe the Leipin later on will comment because Leipin was the first one who pushed PD-L1 as a biomarker for select patient. Yeah. And as you pointed out, there are a few FDA approved the antibody was using for standard to select patient. For example, I think in lung cancer, I believe it's using SP142.
Each drug has its own.
It's different, yeah. It's different.
It has its own companion, so that's a disaster.
I could point it out that there are two antibodies, 28.8 and the other one you mentioned, 23C. Yeah. Both of them are recognized as the extracellular domain of PD-L1. So I assume those antibodies, my personal bias, although that need the data to prove that two antibodies probably better than the other antibody which recognize the cytoplasmic domain. Actually, yesterday, I think you commented on that. Yeah. That because it's a cell surface protein that if we want to detect it as a marker, it is better use the antibody recognize the extracellular domain instead of internal domain. But unfortunately, that there are a few FDA approved antibody which used for detection, they recognize the cytoplasmic domain, which is buried inside the cell. So, but that probably need to systematically to test it. As you pointed out, different kind of anti-PD-1 therapy, they all come with their own antibody for selection patients. So it may not be as easy to compare, but I think it's worthwhile to do that, to do a systematic comparison. I don't know whether Leipin have comment on this.
So I think the best explanation to offer right now for the This is, you mentioned these two mystery. One is the highly positive. It's at more than 50%. Still, response rate is like 50, 60. It's not 100%. Why? So the IH showed that we actually did some IHC on lung, and almost, I think it's 12 to 15%, which is high PD-L1, but it's no T cells. So this could be one explanation, which is they have some kind of spontaneously expression without T cell infiltration. So it's not. So that might be the one which need to be screened out. So, but clinically, I don't know why in every hospital, it's very hard to convince them to do PD-L1 and T cells. They don't want to do T cells. Okay, so this is one thing. So for other group, which is you have PD-L1 negative, but still response, like 10, 15%. So that I think is probably two best offer right now, right? One is the coagulation, another is the biopsy location actually, because the molecular clear is not homogeneous.
Right.
I mean, like it is kind of cluster, which we see that. So you might miss.
Maybe I can make a comment that kind of PD-L1 is the expression pattern, why PD-L1 positive do not respond. All this stuff need to be systematic study. But I can use another one, PARP inhibitor. We all know PARP inhibitor was target BRCA mutation, right? Not every BRCA mutation positive patient respond to PARP inhibitor. The reason is because of the intrinsically there are other driver mutation gene was mutated. It's been one by one been discovered. c-Met is one of them. So whether the same thing will happen in the PD-L1 positive patient in which PD-L1 positive by regular detection yet do not respond to anti-PD-1, maybe there are some other gene have been mutated and then make them resistant. It's very similar to PARP because the PARP inhibitor, not all many BRCA mutation patients respond, but not all of them.
Yeah, at least we know that EGFR mutation with a high PD-L1 expression, they don't really respond. And there might be some other drivers that we did not discover yet, but I think it's minority. The most reasons probably are T cells and other microenvironment things that we have to conquer in the future.
Because we are far behind the schedule, so I have to close the session here. Let's thank for Professor Yang.
Thank you.
Okay.